Good evening, everyone. Happy NMO Awareness Month, happy MS Awareness Month, and happy Autoimmune Disease Awareness Month. My name is Samira, and I'm a patient living with seronegative neuromyelitis optica spectrum disorder. I'm also the founder and executive director of the Samira Foundation, an international nonprofit organization dedicated to raising awareness of NMOSD, MOGAD, and other rare neuroimmune conditions. We're very passionate about building communities of support for patients and their caregivers, supporting research and fellowships, and advocating on behalf of patients. We're proud to be patient-led, patient-powered, science-driven, and therapy agnostic. And on the topic of science, today we'll be talking about a very important subject in our community, and that is immunizations for the immunocompromised like me and you. So today we're going to be joined by Dr. Elias Sotirchos, who is an Assistant Professor of Neurology and the Director of the NMOSD and MOGAD Clinic at Johns Hopkins University School of Medicine. He has a presentation that he'll be sharing with all of us today, and then we'll conclude with the second half of a live Q&A. So please don't be shy. Feel free to enter questions into the chat. This is a safe space. We'll try to answer as many questions as possible. And just a couple of housekeeping items. This webinar is being recorded. So in case you have to leave or want to reference it later on, you can always go to TSF's YouTube channel to watch this webinar. And a very special thank you to Alexion for their support of this program. And with that being said, I'd like to introduce you all to Dr. Elias Sotirchos.
Thank you so much, Samira, for that introduction. And thanks for the invitation. It's a pleasure to be here and discuss this important topic. So I was tasked today to discuss a bit about vaccines and immunizations for people specifically who are immunocompromised, as many people, most people with NMO and MOG antibody disease and other neuroimmunity disorders often are due to the need for continued treatment in order to prevent relapses of their conditions. Now, just wanted to start with a brief overview of what are vaccines, what are kind of the major types of vaccines, and what are we aiming to accomplish by giving a vaccine. The vaccine is essentially what we're trying to do is to introduce a virus or a bacteria, so some kind of pathogen, into somebody's body in order to induce an immune response against it that can be protective so that you don't actually get infected with that virus or bacteria in the future. And this is kind of a safer way to do it than getting the infection in and of itself, since many of these infections are infections that can cause either significant disability, hospitalization, or even death. And so doing it in this way by giving either a part of the virus or giving it after it's been killed or weakened can kind of get the benefits of getting that immune response that can be protective for someone so that they don't get complications or even get the infectious to begin with in the first place, but avoiding kind of the negative consequences of the infection itself. Now, the kind of oldest and kind of type of vaccine is kind of what we would call a live attenuated vaccine, which means that you take a virus and you weaken it in the lab and then you administer it. So it's still a live virus. It's still the virus that would cause infection otherwise, but it's been weakened to the point that it can't really cause a significant infection if once it's injected or given by mouth sometimes, depending on the kind of vaccine. And the kind of first example of this is the smallpox vaccine introduced in late 1700s. Now, moving on from that, another way to do it is to actually kill the virus or the bacteria and then inject it. So that way it's completely killed. It has absolutely no capacity to cause infection. And examples of this are the polio vaccine, flu shot, pertussis, which is a kind of bacteria, a typhoid vaccine, hepatitis A, and others that are listed here. Another example is what's called a toxoid vaccine. So this is where there are bacteria like diphtheria and tetanus that the main issue isn't necessarily the bacteria itself, but it's toxins that the bacteria make. So it kind of secretes them, it like keeps churning them out, and then those go on and they can cause various problems, such as with tetanus, where it can cause actually like paralysis and muscle spasms. And so In this case, what we do is we take the toxin that tetanus normally makes, it's inactivated, and then it's injected, and there's an immune response against it. So that way, someone will be protected if they get exposed to tetanus and that specific toxin. Other ways to do it is not necessarily to inject kind of the whole thing, but to inject only parts of it. So you can take an ingredient of the microbe that you're interested in immunizing against, and then you can inject that either by itself, or you can attach it to something else that can go in with it as well. So there are various ways to introduce that. And then more recently, kind of, we have examples. I'm not going to go into all of these in detail, but more recently, we have examples of what are called RNA vaccines, which most of us, all of us must have heard about, especially with kind of COVID-19, which here, instead of introducing directly a whole bacteria vaccine or a virus or a whole bacteria or just a part of it, you introduce actually this recipe to make a part of the virus. And then what that does is it goes into a normal human cell that makes that ingredient of the virus. And then your immune system attacks it and you get a response to that specific protein that you're interested in your body making antibodies against. This here kind of shows like the main principles of this process. So vaccine is given, a cell here gobbles it up essentially, and then it kind of shows it to other immune cells so that they can attack it essentially. And this is the normal process. It's what our body would do with any sort of foreign material, including the virus itself or a bacteria, if we're trying to fight it off. And then what happens is there are two kind of main arms of the immune system that fight off infections after kind of this point. One is what's called the B cells, which we see here. And these are the cells that after they're exposed to the kind of ingredient of interest for the virus or the bacteria that they're trying to attack, they start to churn out antibodies. Those are these little Y-shaped things that we see here that protect us from getting that infection, and they can latch onto it, and they're circulating in our bloodstream, and so they can prevent us from getting the infection. The other kind of main part of the immune response is what's called T cells, which we see here. And these are cells that they don't churn out antibodies or anything like that, but they can actually directly attack cells that are infected with a virus or directly attack bacteria or things like that in order to fight them off. Now, vaccines have been one of the main things that has led to an increase in life expectancy over the past 100 years. We see here an example just kind of in terms of the decrease in the number of cases of all of these vaccine preventable diseases, specifically from United Kingdom, but the data is very similar across the world. This is estimates from the CDC for the number of illnesses, deaths, and costs prevented by vaccination of children born between 1994 and 2021. So again, just over that period of time, routine childhood vaccinations are estimated to prevent a total of 1 million deaths, save $2 trillion, and prevent 472 million illnesses, including 30 million hospitalizations. I think one important concept that's very important, especially for immunocompromised people, is the concept of herd immunity. And so what this is that it's not to be that there's a critical threshold of people in the society and in the society that surrounds us that have to be immune to something in order to prevent it from transmitting. And so here what we see is an example of where nobody's vaccinated. And so what happens is one person can get infected and then they can pass it on to everybody else because nobody's immune to it. So it's very easy for this to become transmitted and everybody to then subsequently get exposed to the virus or bacteria or whatever pathogen we're discussing. Here's an example where vaccination is available. You have many people here who are vaccinated and immune. They're shown in yellow. But many people are also not vaccinated, either due to choice or either because they can't, such as people who have cancer or undergoing chemotherapy, or people who are immunocompromised and maybe they get the vaccine, but it doesn't work as well because their immune system cannot react effectively to mount a good immune response. And so then what happens is if somebody, let's say here, who's vulnerable gets that infection, a lot of the vaccinated people won't get it, but some may, because vaccines, just as any medication, any sort of intervention, are not 100% effective. But it can still spread kind of throughout this group and infect many people, including people who are immunocompromised or who have cancer and are going chemotherapy, things like that. Whereas in this situation here that we're seeing here, where we have, again, one person gets the infection, but you have all of these people in yellow who are immune to the virus. Let's say that it's a virus here and are vaccinated. It can't spread effectively. And this is really critical because I wanted to imagine that these people who are flu here and are susceptible, it's not because they didn't get the vaccine or something like that or the choice, it's because they're immunocompromised, like people who have an MO and are on immunosuppressive medications, or people who have cancer on chemotherapy. This kind of highlights the importance of not only vaccinating people who are immunocompromised, but also vaccinating people who are otherwise healthy in order to protect those who are vulnerable and susceptible to getting these sorts of infections. Now, this moving on, I think it's important to discuss kind of these are general principles that kind of come from what I was just discussing about people who are immunocompromised and vaccinations. And I have, throughout this kind of talk, I have a few slides that are borrowed from guidelines from not neurological diseases, actually, but from people. For example, here, these are guidelines from an oncology society or guidelines from rheumatology societies, since these are also people who are immunocompromised and immunosuppressed for a variety of reasons. But overall, people who are immunosuppressed are at an increased risk for infections overall, due to the fact that their immune system is suppressed and they cannot fight off infections as well. And we saw this, for example, during especially the height of the COVID pandemic, where we saw that people who were young and otherwise healthy generally did well with COVID infections. So we saw that often people would, again, it could have a bad cold or a bad flu-like illness, but generally for the most part, people who were immunocompetent were doing well. But we saw that especially people who were immunosuppressed, people who were elderly, people who were cancer patients undergoing chemotherapy, or people who had comorbidities such as diabetes, COPD, heart disease, things like that. Those people were especially at risk to have severe complications or even death from COVID infection. And so it's not just the risk of getting the infection itself, but the severity and risk of complications is also higher since people who are immunocompromised can't effectively fight off the infection. Additionally, one of the problems with immunosuppression is that one of our goals then would be, let's vaccinate people who are immunocompromised in order to protect them as much as we can. But one of the problems is that because of their fact that they're immunocompromised, vaccines may not work as well. And we're going to go over a little bit kind of guidelines for vaccinations and specific medications and how they may impact vaccine efficacy in subsequent slides. Another issue also is that live vaccines. So if you remember, we went over the types of vaccines, and there are vaccines that are weakened that contain a virus that's very much weakened, but it's still alive. And so while somebody who has a normal immune system can very easily fight off that weakened virus, somebody who's immunosuppressed, even though that virus has been so weakened that it wouldn't cause disease in people with normal immune systems, it could actually cause disease in somebody who's immunocompromised. And so in general, as a rule of thumb, live vaccines are not appropriate in people who are on immunosuppressive medications. So because of all of these issues, really the best time to get vaccinated, if possible, is before somebody becomes immunosuppressed, either because they were vaccinated when they were healthy with age-appropriate immunizations, or because you have some time to do it before you start kind of a long-term medication. Although I have to say that's often very challenging to do, especially with diseases like NMO, where we generally are not comfortable leaving somebody off treatment. Like we want to start treatment as quickly as possible due to the risk of disability with even a single relapse. So we really don't want to risk that in general. And then going back to the issue of herd immunity that we discussed, it's important that to make sure that close contacts, caregivers, and the society at large is vaccinated at a threshold that's high enough in order to protect immunocompromised individuals. In terms of specific vaccines, we're going to discuss this more in detail for some specific medications that have some different indications. But in general, for people who are immunosuppressed, these are the vaccines that are generally recommended aside from the kind of routine vaccination schedule that all adults are recommended to follow. So kind of the exceptions and additional vaccines that are recommended for people who are immunosuppressed. Number one is the shingles vaccine. So shingles is caused by the chickenpox virus, actually. And what happens is when we get chickenpox, the virus kind of enters our body. We fight it off in general, but then it can just stay there, kind of laying dormant in the body, and it never really goes away. It just stays there sleeping. And then when somebody becomes immunosuppressed, or as we get older, it can wake up and then cause shingles. And shingles, while shingles in and of itself, often, again, it's uncomfortable. It can cause a lot of pain and other symptoms, but often it may resolve without too much left. In people who are immunocompromised, especially, it can even spread and involve the whole body and cause a systemic infection that can be very severe. Also, like shingles can cause significant residual pain. So even if the rash, like you fight it off, it goes away, people can be left with severe, what we call post-herpetic neuralgia, which is a kind of very severe nerve pain that can occur. And so generally, it's very important to be able to kind of prevent this. And we do have very effective shingles vaccines available. Now, they're recommended universally for people who are over age 50. But in people who are immunosuppressed, it's recommended that any adult who's immunosuppressed or will be immunosuppressed receive this vaccine, and specifically what's called the recombinant, which is the non-live. So there's an older shingles vaccine that is live. But as we mentioned previously, live vaccines are generally contraindicated in people who are immunosuppressed. Another important vaccine is the pneumonia vaccine, which is recommended also for all adults who are immunosuppressed. It's universally recommended for those over age 65 to get a booster. It's given in childhood, of course, as well. But we recommend that all people who are immunosuppressed receive the pneumonia vaccine as well. More recently, there have been vaccinations approved for RSV, which is a virus that causes a lung infection, especially in young children. So it can cause what's called bronchiolitis. But it can also affect people who are elderly and immunosuppressed and cause pneumonia and severe pulmonary complications. It's universally recommended now for those over age 75, but for people who are immunosuppressed, it's recommended at an earlier age, including ages above 60. And then the HPV vaccine is also recommended for people immunosuppressed ages 26 to 45 if they haven't been vaccinated previously. HPV is a virus that causes things like genital warts, but also causes skin cancer, cervical cancer, oral cancer. So it's associated with a variety of cancers and is one of the main vaccines that can prevent cancer. And so it's universally recommended for those under age 26. But if people are immunosuppressed and have not been vaccinated previously, it has been recommended for ages 26 to 45. Another recommendation that exists that came out of these recommendations from the Rheumatology Society is for the flu vaccine. So generally, the annual flu vaccine is recommended for everyone, but there is some recommendation perhaps for using higher dose or what's called adjuvanted flu vaccine, where the flu vaccine has an extra kind of stimulant for the immune system so that it can mount a stronger response. And if it's available and not difficult to obtain access to, it's reasonable for that to be used in people who are immunosuppressed. Another important aspect, especially when we're starting treatment, and we don't have a lot of time to administer all the vaccines because we're planning on starting an immunosuppressive therapy soon, is that in general, multiple vaccinations can be given on the same day rather than giving them on a different day or trying to space them apart. Our body responds to hundreds, thousands of antigens every day, our immune system. And administering multiple vaccines the same day is okay and endorsed by the American College of Rheumatology. This is an approach that I often implement with my patients. Let's say that I know we're going to start rituximab or like a medication like that very soon. I want to get as many vaccines in as I can before we start that medication. given that we know that after people start that medication, the vaccines won't work as well. And so we will administer multiple vaccinations the same day and haven't encountered any issues. Similar things can happen with Ultomiris and Soliris, which we're going to discuss, where it's very important to make sure that people are vaccinated, especially for meningitis, before they start treatment. We administer multiple vaccines, meningitis, pneumonia, on the same day, and we haven't observed any significant issues. Moving on, one of the main concerns that often comes up when we're discussing vaccination with patients is, could a vaccine trigger a relapse if I have NMO, or if I have MS, or if I have MOG antibody disease? And I would say that in general, the data that exists, which there are data from very, very large studies, mostly from multiple sclerosis, just given that it's a much more common disease and also a disease that has been recognized for a much longer period of time. Let's not forget that NMO really became defined as a disease more so in 2004 with the discovery of the aquaporin 4 antibody, and MOG antibody disease was only really recognized more recently. And they're both rare diseases, so we don't have as much information. But in general, very large studies in MS, I just have a couple here, but there are multiple more that we could reference here, have shown that there is no clear association between vaccinations and risk of developing MS in the first place, or with having relapses once somebody has MS. So this is an example of a study here of 125,000 people in France who received at least one dose of a COVID vaccine. Well, some of them, 80% of them had received COVID vaccines, and looking at kind of what the risk of relapse was in the period after the COVID vaccine compared to other times. And they really found no increased risk. There was perhaps a very tiny signal in a booster dose in people who had already had a lot of MS activity, especially who were not on treatment. But in general, I would say that there's a lot of data with flu vaccines. This is one here is with COVID vaccines and other vaccines that have not demonstrated an association with relapses. And even more so, I would say that once somebody is on treatment with an effective disease-modifying therapy, vaccines have clearly not been associated with risk of relapse. Now, moving on, I just wanted to go through kind of specific therapies. I'm not going to take too much time because I wanted to leave as much time as possible for questions. But we're going to start with B-cell depleting therapies. So when we say B-cell depleting therapies, these are treatments that essentially we infuse them IV and they go and they kill B cells. And as I showed in the first slide, B cells are important because they're the cells that recognize an object, a virus, as being foreign to our body, and they go and start churning out antibodies so that they can protect us. But if we're killing them, as we see here with rituximab or with inebilizumab or Uplizna, that will reduce our ability to mount those immune responses. Importantly, though, and one thing that's really interesting is that if we've been vaccinated before we started, those responses are actually maintained for many years, decades after vaccination. So it's more so a problem with mounting new immune responses after we've started these treatments. Pre-existing responses are generally pretty well maintained, kind of highlighting that importance of having followed the age-appropriate vaccination schedule and getting in as many vaccinations as we can before starting treatment. Now, once somebody has started treatment, what we see is that vaccine responses are pretty much weakened significantly. And so I'm going to walk you through this slide here. What we're seeing here down here is how many months it's been since the last rituximab infusion or ocrelizumab. It's the same thing essentially for this purpose. These are both medications in people with multiple sclerosis that we're looking at here. And then looking at here, how high of an antibody level were they able to have in their blood against COVID-19 after having gotten a COVID vaccine? And these here just show kind of, this is the Pfizer vaccine, this is the Moderna vaccine, is what these here abbreviations mean. And what we're seeing is that there was, in each dot is one person. And what we're seeing here is that there are a lot of people down here who had zero antibodies essentially made in response to the vaccine. What we also see is that the longer that it's been since your last infusion, the more likely people who are on these medications are to make antibodies. Um, and so that's an important kind of implication for trying to time vaccinations in people who are getting rituximab or medications like that, such as Uplizna. Now, one other, though, important thing is that even if somebody doesn't make antibodies, it doesn't mean that the vaccine didn't do anything. I think this is very important to understand. I'm going to walk you through this figure too. It's a little bit busy, but stay with me. So here what we're seeing is we're seeing antibody levels again here. Each dot is a single person in people who got COVID vaccines. And I want to focus you on here in the red rectangle, where again, anti-CD20 means rituximab or medications like rituximab. Now, what we see is that a lot of people did not make antibodies. Those are the people who are below this dashed line, but a lot of people did. And here we see again in this figure here kind of similar things as we saw previously, where those who had the most time since their last infusion were the ones who were more likely to have a vaccine response. So the people in blue here are the ones who did have a positive antibody response. The people in red are the people who did not have one. And you see that the longer it's been, the more likely people are to have an antibody response. However, want to draw your attention to this slide here. So this one here does not show antibodies. This one here shows T cell responses, which are those other types of cells that I showed in the first slide. And what we see is that even though the people in red here did not mount T cell responses, they actually had pretty significant T cell responses to COVID once we tested their blood for those responses. And so this shows that even though they weren't able to make antibodies, they did have some immune response by receiving the vaccine, which is expected to be beneficial and to protect them to some extent, though not as much as we would like if they had a very high antibody response. But some protection is still provided against COVID by doing this. So because of that, all those implications, in general, if we can, we try to time vaccinations that need to be given to patients who are on rituximab around the time the next infusion is due, but you want to not give it immediately before and then get the rituximab or the Uplizna the next day. You want to allow for at least 2 weeks. Generally, I tell my patients 3 to 4 weeks is probably ideal before an infusion to get any vaccines that are indicated. Now, again, one of the problems, though, is like the flu vaccine, for example, has to be given on a specific schedule. You can't, there's no point in getting the flu vaccine in the summer when we're out of flu season. So with that vaccine, in general, we can't really try and time it. If we can, that's better. But in general, it should just be given on schedule around kind of October, November, which is around the time that most people are going to get their flu vaccines in preparation for flu season. But other vaccines that are indicated, it's good to try and time them if possible. Moving on, discussing what's called tocilizumab, also known as Actemra, and then satralizumab, Enspring. These medications also have a lot of effects on the immune system, but they also act on B cells, as we're seeing here. Interestingly, though, vaccine responses to the flu and pneumonia vaccines, at least, are preserved in people treated with these medications as long as they're not on something else in addition to Enspring and Actemra. But live vaccines are still contraindicated. But that's something that is somewhat reassuring that these people who are on this medication, in contrast to people who are on rituximab, are generally able to mount effective antibody responses. Then I'm going to move to the kind of last category that we're going to discuss today. Again, the general principles that we discussed in the earlier slides apply to most of the medications, including things like mycophenolate that a lot of people may be on, thioprin, methotrexate, all of these kind of immunosuppressive medications. Soliris and Ultomiris are a bit of an exception, though, to some of these rules that we discussed previously. And I think that's why it's going to be important to kind of cover these specifically separately. So what these medications do is instead of acting on the B cells, which are the cells that make antibodies, they act on a part of the immune system that's called the complement. And what this does is it does a lot of things, but the most important thing that it does at the end, which is the part that these drugs block, is it is able to poke holes in bacteria. And specifically, this is very important for bacteria that have something called a capsule around them. And the main bacteria that we're concerned about in people who are on these sorts of medications are the bacteria that cause meningitis specifically. Meningitis is an infection of the covering of the brain and spinal cord. And this is an infection that can be quite severe or even fatal if it occurs, especially if prompt treatment with antibiotics doesn't occur or is delayed. However, fortunately, there are vaccines available that are quite effective at preventing meningitis and are now administered at the population level and are part of the routine vaccination schedule. And so this is why it's very important and it's recommended that people who are receiving these medications receive vaccinations for meningitis. So there are two different types, the ACWY, that's just four types of the meningitis bacteria, and then the meningitis B, which is the fifth type of it. And what's recommended is to give these vaccinations before starting treatment, at least 2 weeks in advance, completing the vaccination series. And then boosters are recommended every 5 years for this one, every 2 to 3 years for the meningitis B, as long as people are continue to be on these treatments. Additionally, other what we call encapsulated bacteria are the pneumococcus, which is the one that causes pneumonia, and H. flu, which is a kind of bacteria that can also actually cause meningitis and other infections too. And it's recommended that those are also administered in people who are treated with Ultomiris or Soliris. If people are immunocompromised when they get the vaccines, or if we know that they're going to start the medication less than 2 weeks after the vaccination, we in general recommend antibiotic prophylaxis. So people take an antibiotic kind of every day in order to protect them from developing meningitis. Now, these are all kind of exceptions because we didn't really discuss meningitis vaccinations previously. I mean, they're part of the routine vaccination schedule, but not specifically kind of incorporated into recommendations for people who are otherwise immunosuppressed. One other kind of exception to the rule with these medications is that live vaccines are not contraindicated. So because these medications act on a part of the immune system that isn't really important for viruses, live vaccines can still be given. And the other thing is that vaccination responses are generally expected to be normal for people who are on Ultomiris or Soliris, as long as they weren't on another immunosuppressive medication recently, or they're not on another immunosuppressive medication at the time that they're getting the vaccine. I want to stop there and open it up for questions.
That was a great presentation. Thank you so much, Dr. Sotirchos. So yes, anyone who has questions, please feel free to enter them into the chat or the Q&A function. But let's see what we've got already. I have some questions lined up. All right. Okay, so I oftentimes see some discourse on the Facebook groups about how some patients feel like they got NMOSD or MOGAD because of their vaccines. And obviously, we know that the vaccines are not the cause of our diseases, but what can you say about, or do they trigger something that already existed in our bodies? Like, I want to debunk this myth of
Yeah,
vaccines being the cause of our diseases, because it's not the cause of our diseases.
I think that's a great question. So I think that complicated discussion. I think that we can start with a few things. I think first of all, it's it's a very powerful kind of anecdotes are very powerful, I have to say. And it's kind of very intuitive to us that, I got a vaccine and then let's say a month later I had my first NMO attack. Was it the vaccine? I think one of the problems sometimes with that is that it's there's a lot of things that could just be coincidence, right? And vaccines are administered at a kind of mass population level. So with COVID, for example, there were billions of people vaccinated in the span of a couple of years. So at any given time, there were people who, let's say I had a crystal ball, I know that there are people who are going to develop MS or NMO or MOG antibody disease. And they just happen to have a vaccine because, again, if we vaccinate 100 million people over the span of, again, just a few months, for example, as occurred in the United States, there would be people who would develop those diseases anyway during that time span. Now, I think that in general, I would argue that if, let's say, the COVID vaccines, for example, were triggering an exacerbation of NMO, MS, MOGAD, the best way to kind of examine that is to look at a population level. So to look at kind of, are we seeing an increased frequency of these diseases after the rollout of those vaccines and mass vaccination campaigns? I would argue that we're not, and there are studies that have looked at this. I mean, the US is not the best place to look at this as a problem just because of the way our healthcare system is structured. But places that have more kind of centralized healthcare systems where they can track people more effectively because it's all a public system, such as in the Scandinavian countries or in the United Kingdom. Generally, the conclusion of those studies was that there was not an increased risk of things like myelitis, encephalitis, things like that. Now, there were with some, for example, the AstraZeneca vaccine was associated to some extent with perhaps a somewhat mildly increased risk of myelitis. Now, moving back kind of to the issue of like vaccines causing NMO, causing I would argue that in the vast majority of cases, a vaccine was not causal in terms of causing the disease itself. NMO especially, I would argue, I would say that in NMO, we know that now there have been many cases described where people were developed NMO, but they had blood draws many years before for other reasons. They were blood donors or something like that. And if you go back and test their blood, they had NMO antibodies at the time. And so we know that NMO, especially aquaporin 4 antibody NMO, probably develops years before people have their first attack. Now, then the question is, if somebody had a vaccine and that had an attack, could the vaccine have somehow triggered the attack? I would argue that in most cases, no, and it might have just been random. Although it is plausible that maybe in some cases, like having some inflammation could kind of allow an immune response that's already there to kind of emerge. The thing is, though, that it's quite possible that the infection in and of itself, getting the flu or getting COVID or getting all of these other infections, could quite likely have done the same thing in this person. So it wasn't a matter of if they would develop their first attack of NMO, it would have happened at some point, but maybe it was the vaccine. Although I have to say, like, we don't have great evidence for that based on what I was saying previously. For example, in MS, flu vaccines, COVID vaccines have not been associated with an increased risk of relapse when you get them. Now, MOG is an interesting question because MOG is kind of more strongly post-infectious when it happens. Often people have an infection beforehand or something occurring beforehand. Sometimes vaccines may occur beforehand as well. And so it's a difficult situation. Like I have some patients, for example, who, and again, I think it's important to understand what we mean by something being vaccine associated. Like we're really looking at a time frame of, I would say, like 1 to 6 weeks at most, probably 1 to 4 weeks after a vaccine. So in MOG, I would say that sometimes we might see this. Now, in general, large studies have really failed to show kind of clear association, but it is a rare disease that's recently described. And so my argument in those cases is that, let's say somebody has their first MOG attack 1 to 4 weeks after getting a flu shot. In those situations, I mean, it's tough to say if it was truly the cause or not. But given that MOG might be a one-time thing and it might not happen again sometimes, I think it's reasonable to potentially discuss what the risk benefit of that specific vaccine was, not vaccines in general, but that specific vaccine, and maybe avoiding the specific vaccine that was associated. But again, that's a situation where that person would not be immunocompromised, right? Because the talk today, I'm trying to focus on people who are immunocompromised. if somebody, let's say with MOG had a single attack and doesn't go on treatment, because most people would not treat somebody with MOG with the first attack, it's likely that they're not immunocompromised. So there, it might be that the vaccine might not be as important, especially if we have herd immunity to protect them by avoiding the specific vaccination that was associated with an attack.
All right. Okay, we have some questions in the chat. Thank you for the excellent presentation, Dr. Sotirchos. Can you share what reservations your NMOSD patients typically have regarding vaccines?
Yeah, no, I think that kind of comes back to what I was just discussing. I think the main question, the main issue is the concern about it triggering an attack. And I think that, again, my main reassurance about that is one is that I think that there's not good evidence support that that's the case. And I would say that even if, let's say that vaccines can trigger relapses, which I'm not endorsing as a view. If somebody's on an effective NMO treatment, even if we don't see relapses in people who get vaccines. And I would argue that also if you're on an effective NMO therapy, you really need the vaccine because you're immunosuppressed. So the risk of getting a bad infection is much higher than getting a relapse.
I received my first 2 doses of rituximab in January, and I will be scheduled again in late June. When is the best time to get vaccinated for shingles?
Yeah, it's a great question. So again, as I was saying during the talk, shingles vaccinations are recommended. The shingles vaccination is recommended in all adults who are on immunosuppressive medications like rituximab. Specifically, it's the Shingrix one, which is the non-live. So it's not live and can't cause infection. In general, with rituximab, the best time is about kind of 3 to 4 weeks before the infusion for that vaccine. Now, the shingles vaccine is actually 2 doses. It's recommended for them to be 2 to 6 months apart is the vaccination series. So in general, what I tell my patients, get their first one about 3 to 4 weeks before an infusion is due. And then I stretch it out to the second dose is 6 months after the first one. That way it will also be given at least a few months after the rituximab has been given. So it's kind of starting to wear off a little bit.
Sometimes the cause of patients' vaccine hesitancy is the lack of a strong and trusted relationship with their primary doctor. Where else can these patients turn for more information on vaccines and their safety for immunocompromised patients?
It's a great question. I mean, I do think that, again, I'm not sure if primary doctor referred to the neurologist or the primary care doctor. I do think that overall kind of events like this are very important, and like organizations like the Spire Foundation and others having materials for this. Additionally, the CDC and what's called the ACIP, which is the panel that convenes and gives recommendations for vaccinations, all have really like patient friendly, like they have kind of like their website has patient friendly stuff and stuff that's more geared towards physicians and experts in the field. So I would argue that that is also, I think, a very good resource to go and read about people like the vaccination for people who are immunocompromised.
Travel medicine doctors know a lot about this stuff too, obviously, right?
Yeah, I'd say I'm sorry, primary care, you said, or
Travel medicine.
travel medicine, yes, and immunology as well. So there are
Yeah.
people like allergy and immunology physicians who are familiar with this as well for people who are immunocompromised. So that might be a resource too, yes.
Okay. I have stiff person syndrome and have been told not to get vaccines because I have IVIG infusions every 4 weeks. I should be getting immunity through the IVIG. I also get hives the day after receiving a vaccine, Shingrix, COVID, flu, RSV, etc. Also got hives after Paxlovid. Could the hives be due to my immune system?
That's a great question. So first of all, IVIG, IVIG is not really immunosuppressive, I think is the good thing about IVIG, as long as you're not on something else as well. So sometimes people are on IVIG plus something else, but IVIG by itself doesn't really suppress the immune system. So in general, um, people are not considered immunocompromised, kind of, so the things that we were discussing and talking about necessarily fully apply. However, because what IVIG is you're getting a bunch of antibodies from healthy donors, essentially.
Yeah.
You're being given antibodies to things like COVID, flu, RSV, shingles by virtue of getting these. And so vaccines in general may be less effective because of that, because like we're injecting it, but you already have a bunch of antibodies, and then they go and they latch on and they prevent your immune system from trying to recognize it and fight it off. So in general, with IVIG, vaccines may be less effective, and the hives could be because the antibodies from the IVIG are going and reacting, let's say, to the vaccine that you're getting. So it is potentially possible, yes.
I am NMO aquaporin 4 positive, and a neurologist in Chicago told me not to get the COVID vaccine because of my lightest symptoms after the shot. I had had 2 or 3 prior COVID shots. However, I have since had COVID a few times. Is that just as effective?
So this is a great question. So I think that one of the things that happens is that with NMO, MS, MOG, sometimes people have worsening symptoms after a vaccine, or they might have worsening symptoms after an infection or like a UTI or the flu. And we conceive of these in general as not being what we would call true relapses, where there's new inflammation in the spinal cord and the optic nerve, but as being reemergence of old symptoms because of the fact that there's old damage kind of there. And then when our body becomes unable to compensate for that injury that has occurred in the past, these old symptoms come out. And we often see this with infections, with fever, with overheating in the summer. Sometimes people have issues. So I don't think necessarily that unless it was kind of a true attack and MRI showed something new or something like that, it's not unexpected sometimes when people get a shot, you can get a fever or like feel unwell. I mean, that's kind of expected. Your immune system is trying to fight off the um the vaccine, and so that's desired actually. But it may be that people might have worse symptoms at the time, like some symptoms might get worse. Sometimes tingling, pain, things like that might emerge as worse. So I don't necessarily think that that's a contraindication. Now, there was a question, I think, about having gotten COVID and if that provides protection. And so it does provide protection. Um, our body gets immunity through infection or through vaccines. But I would argue that if you're immunosuppressed, it's possible that that immunity might not be as long lasting as it would be if you were immunocompetent. And so it would be reasonable to kind of get the COVID boosters periodically in order to make that immune response stronger and prevent further COVID infection in the future.
I'm on Soliris, so I receive infusions every 2 weeks. Is there any specific timing for receiving the shingles and RSV vaccines?
Great question. So with Soliris and Ultomiris, there is no issues regarding timing. And also, we expect the vaccine responses to actually be normal in people who are on those medications, as long as they're not on something else or like at the same time another immunosuppressive medication, or if they've gotten rituximab recently or something like that.
I had a mild case of COVID while on Ultomiris. I was vaccinated with a Moderna vaccine. Is it safe to take Paxlovid if I get COVID again? I was afraid to take it.
That's a good question. So I think that it is safe in general. I would argue that it might not have a huge benefit for somebody who's on Ultomiris, because somebody who's on Ultomiris is immunosuppressed, but they're not really immunosuppressed in their ability to fight off COVID. So with Ultomiris, it's really kind of more specific for the meningitis risk that I was discussing, as well as pneumonia. But viruses, your immune system, if you're on Ultomiris, you're generally able to fight them off normally, actually. So the benefit of Paxlovid is kind of, I would say, probably much less in people who are immunocompetent and not immunocompromised. So I think that it would be reasonable to defer, especially if your COVID was only mild and you have been vaccinated as well. There's only likely to be a very marginal, if any, benefit from taking the Paxlovid.
So given that Ultomiris just became the fourth FDA-approved therapy for NMO and some other indications as well, if someone's doctor suggests that they be put on Ultomiris or Soliris and they're not vaccinated, what do they have to do to get started? Is it just the meningococcal vaccine?
Yes, so it is the two meningococcal vaccines that are required in order to start Ultomiris or Soliris, and they have to be given at least 2 weeks prior to the first dose. If it's an urgent situation and you can't wait 2 weeks, we often will do the antibiotics that I was discussing previously as a preventative. Now,
Okay.
one other point that I actually wanted to discuss and didn't bring up is that I also like, because of this requirement with Soliris and Ultomiris, I often may vaccinate people with a new diagnosis of NMO, even if they're not going to go on those medications, just in case we end up using those medications down the line. You see, so like, let's say I'm going to start um, Uplizna in a patient, and they were just diagnosed, and I know that Uplizna will decrease the effectiveness of vaccinations. I think it's reasonable to give meningitis vaccines, even though they're not required before starting the Uplizna, just in case a few years down the line we have to switch for any reason to something like Ultomiris.
These are rapid fire questions. Okay. It seems for me personally, NMO, aquaporin 4 positive, whenever I get any vaccine, shingles, flu, I end up with some version of the illness. Response has always been if I didn't get the vaccine, it could have been worse. The response to the vaccine does trigger NMO responses. So I'm fearful for getting numerous vaccines. I'm over the age of 50. Technically, I should be getting most of these vaccines.
Yeah, that's a good question. So, I mean, I think that, yes, unfortunately, vaccines are not 100% effective, and especially more so in people who are immunocompromised, immunosuppressed. So I didn't see the medication listed that this person was on, but it is quite likely that there's probably a combination of two things. One, vaccines, again, are not 100% effective. And two, if you're on immunosuppressive medication, the vaccines just don't work as well. However, I do agree with what people are telling you that it is quite likely that if you had not gotten those vaccines, that your infection could have been worse. And we know that from like data with COVID, for example, with the COVID vaccines don't prevent somebody necessarily from getting COVID completely. But we do know that people who were vaccinated and would get COVID, their risk of death, their risk of severe COVID was much, much, much lower than people who were unvaccinated. Now, I realize that there's a concern about kind of the symptoms getting um, worse after the vaccines. And that kind of comes back to what I was saying about whenever our body is under stress, fever, infections, vaccines, whatever, old symptoms can tend to get worse. But in general, this is not a true relapse where there's like a new injury occurring to the nervous system. It's kind of old symptoms that are worse because of the stress on the body. And once that stressor goes away, whether it be an infection or anything else, generally the symptoms should resolve completely and there is no damage done. So I do recommend kind of getting the infection, especially since you're over age 50, because you're even at higher risk. So immunocompromised and being over age 50, these are kind of more factors that are putting you at higher risk for infection.
Are there any vaccines seronegative NMOSD patients should be more mindful of? Thank you so much for your wonderful slides and sharing your knowledge with us.
Thanks. Yeah, that's a good question. I think that not necessarily, no. I wouldn't say that seronegative NMO patients have to have a different kind of outlook on vaccines. I would say that all the things that we discussed really apply there. Um, Both, and it would kind of be mostly determined based on what kind of immunosuppressive medication they're on, if they are on one. So I would not differentiate kind of my recommendations for somebody with aquaporin 4 seropositive NMO compared to somebody with seronegative NMO.
Given the recent reemergence of measles in the United States, should I check my antibody titers and get a booster if they are low?
This is a great question, and it's a very challenging question for two
Yeah.
reasons. So first of all, yes, there's been a huge reemergence of measles, and it's something that I and my colleagues with whom I discuss this are especially concerned about since we treat people who are immunosuppressed, and it's possible that their ability to fight off measles may be reduced, even if they had been vaccinated in the past. However, I would say that there are probably a couple things here. One is that people who have been vaccinated for measles in childhood with the two vaccine schedule, which I think was instituted after 1965, so anybody born after 1965, generally have lifelong immunity for the most part. And it's not necessarily, even if the antibody levels are low, they're probably still immune because of T cell responses and all these other things that we discussed. That's number one. Number two is that the measles vaccine, it's the MMR vaccine, which is measles, mumps, rubella. It's a live vaccine. And the problem that this is kind of one of the things that I said repeatedly during my talk is that most of these immunosuppressive medications, you cannot give a live vaccine if somebody's on them because it's possible that it could cause an infection, even though it's a weakened virus in it. So because of that, unfortunately, it's not really something that we can do for our patients who are immunosuppressed, but it emphasizes the importance of the herd immunity that I was getting at in my talk. And this is specifically why I and others kind of emphasize the importance of healthy people getting vaccinated for measles, because if we have a good vaccination rate in the general population, I'd say 95% or more of people are vaccinated for measles, we can protect the people who are vulnerable, people who are cancer patients, people who are NMO patients who are immunosuppressed. But people who have NMO, unfortunately, generally can't get these vaccines because they're live.
Two more questions. So I had the measles at 4 years
Oh,
old, now 71 with NMOSD. Would I still be protected?
that's a great question. Probably yes. I have to say, I don't know. I have not looked up data on kind of quote unquote natural immunity to measles. But I would argue that based on the data that we have from the vaccine data, which we administer at very young ages, right? The two doses are given at age 1 and age 4 to 5. I would argue that we have very long lasting immunity. I would expect that similar duration of immunity with measles infection itself. So likely still protected, I would say.
And the final question of the night. What do you tell patients who feel like the potential risks of a vaccine are greater than the risk of getting the underlying infection? If I choose the vaccine, I definitely am getting the vaccine, but I may not ever get the related infection. How do you balance the risks for patients?
Yeah, I think it's a very interesting question. And everything that we do, we're trying to weigh risk and benefit, right? Now, I think that yes, when you get the vaccine, you're 100% getting it. And this is kind of one of the things that we were discussing during, especially kind of at the height of the COVID pandemic when vaccines became available. So not every, well, I would argue probably everybody has gotten COVID at some point now, even if they had symptoms or didn't have symptoms, just given how contagious it is and how widespread it ended up being. However, the vaccines, I have to say, the risks associated with vaccination in people who have NMO and especially who are on therapy are essentially zero, I would say. While the risk of getting the infection, especially if somebody's immunocompromised, so of getting bad COVID or getting pneumococcal pneumonia or getting shingles and then getting what we would call disseminated zoster, where you get a zoster rash on your whole body and the virus can even affect the liver or brain or other organs and cause permanent damage. I would say that there, the benefit of the vaccination preventing that severe complication really the benefit of the vaccination just outweighs any theoretical risks associated with it, I would say.
Well, clearly, this was a very important topic. We had a lot of very pressing questions, and you had an amazing presentation. Thank you so much, Dr. Sotirchos, for um, all of this really important information. In 2025, vaccines and immunizations continue to be an interesting topic. So this was super, super helpful. And yeah, no, thank you so much for all of it.
Thank you so much for having me. It was a pleasure.
Of course. All right, everyone. Have a great night and happy Animal Awareness Month. Bye.